Good afternoon, friends. It gives me immense pleasure to be with you. Kudos to the organizing committee for this wonderful conference. Thank you, Dr. Vijayakumar, for allotting such a quality time for this food care in diabetes. Greetings to all my co-chair, co-panelists, all my friends. My topic will be on pathophysiology of diabetic foot ulcer. காக்க காக்க கால்களை காக்க நோக்க நோக்க தினமும் நோக்க. So importance of advising the patients on self inspection of the foot every day. யாகாவாராயினும் கால் காக்க காவாக்கால் அக்கால் கருகுமே அதிக சர்க்கரைக்கு. So the good glycemic control plays a major role in prevention of the diabetic foot ulcer, one of the causes. Why to worry about foot in diabetes? Because the recent ICMR report says now 100 million plus diabetic population living in India. So we need to take care of 200 million plus feet in our day-to-day clinical practice. It is a major burden for most of the healthcare providers. Basic foot knowledge: foot bear the full weight of the body. As such, they are the foundation of the body, and the health of your whole body rests on your feet. Diabetic foot ulcer is one of the most disabling complications, and it constitutes a major public health problem. And also, diabetic foot ulcer affects 15% of people with the diabetes in their lifetime. So if we want to prevent the diabetic foot ulcer and amputation, we need to identify the high-risk foot in our clinical practice. To do all these things, we should understand the basics and the pathophysiology of diabetic foot ulcer. This you would have seen in our second year anatomy classes: phalanges, metatarsals and tarsals. These extrinsic muscles and the intrinsic muscles of the foot, they play a major role. And the integrity of these muscles very much essential to maintain the medial arch and other arches, and to maintain the posture and the gait. And maintaining this, we can prevent the diabetic foot ulcer and amputation. Yes, we know infection is one of the main causes for the foot ulcer. Now we would like to focus on non-infective causes of the diabetic foot complication. That is, one callus ulcers or tropic ulcers, diabetic bullae, and toe abnormalities. That is hammer toe, claw toe and mallet toe, and PAD, Charcot foot, and entrapment neuropathy. So this one shows the plantar gerosis and the heel fissures due to autonomic neuropathy in the diabetic feet, crowding of the toes and the hallux valgus deformity in non-motor neuropathy patient, intrinsic minus foot. What is the pathogenesis of diabetic foot ulcer? There are risk factors, both the systemic and local factors. Systemic factors: uncontrolled hyperglycemia, so longer duration of diabetes, and PVD, and blindness or visual loss. Old age is one of the systemic factors. What about the local factors? Peripheral neuropathy and structural foot deformity, trauma and callus. Whereas the previous ulcer and amputation, main thing is elevated plantar pressure for a longer period and hallux rigidus or limited joint mobility. So what are the causal pathways of the diabetic foot ulceration? This one single slide covers the entire the pathways of foot ulceration in the diabetic patient. See, diabetic mellitus, here PVD, here somatic neuropathy, that is sensory motor, here autonomic neuropathy. Let us see one by one. Role of sensory neuropathy in the diabetic foot ulcer. So diabetic foot ulcer, poor glycemic control, longer duration. So patient experiences decreased pain and decreased proprioception, which leads to sensory neuropathy, which in turn here painless trauma leading to diabetic foot ulcer. This pathway, building up the callus and painless trauma, Because of the callus, there is a elevated plantar pressure which leads to deformity. Deformity in turn leads to diabetic foot ulcer. What is the role of motor neuropathy in diabetic foot ulcer? So diabetic foot ulcer, longer duration, poor glycemic control, and all other reasons, they lead to motor neuropathy, that is intrinsic minus foot, that is the volume of foot muscles in the intrinsic muscles will be impaired and less. This intrinsic minus foot which leads to foot and toe deformities one side, this side limited joint mobility, that is hallux rigidus, which in turn leads to elevated plantar pressure. The elevated plantar pressure is one of the culprit which leads to diabetic foot ulcer. What about the role of autonomic neuropathy in the diabetic foot ulcer? The autonomic neuropathy, one side altered blood flow regulation, engorged foot veins, joint collapse leads to deformity, in turn leads to diabetic foot ulcer. Whereas due to autonomic neuropathy, there is a pseudomotor dysfunction, dry skin, diminished sweating, which leads to plantar gerosis. Whereas other side, reduced flare response at the end of the day, this autonomic neuropathy leads to reduced delivery of oxygen and the nutrients to the tissues, which in turn leads to diabetic foot ulcer. What about the role of the PAD in the diabetic foot ulcer? In diabetic mellitus, plus or minus smoking, patient with the smoking or without smoking, with the hyperlipidemia, there is a development of endothelial dysfunction, development of the atherosclerosis and PAD, which in turn leads to one side cholesterol emboli and blue toe syndrome, leads to diabetic foot ulcer. Other pathway, reduced delivery of oxygen and nutrients, in turn leads to diabetic foot ulcer. These are the common sites of ulceration in the diabetic neuropathic foot. See the plantar pad of fat, heel pad, all these things. Due to neuropathy, there is a thinning of the plantar pad of fat and mobilization of pad of fat to some other above area and leads to increased risk for the diabetic foot ulcer. The stages of the ulcer development, one is a callus formation, next subcutaneous hemorrhage, which leads to breakdown of the skin and deep foot infection with osteomyelitis. What are the theories of the tissue damage? Here I would like to highlight one important point. During the gait, peak plantar pressure in the forefoot, that is 30 times higher than that of the hind foot. Because of the 30 times higher peak plantar pressure, the patient is very vulnerable. He gets ischemic in walking repeatedly. And in the diabetic population, there is a delayed recovery from the anoxia in the diabetic population. And also, continuous high level risky activity. One side it is a elevated plantar pressure. More than that of the elevated plantar pressure, if there is a continuous high risk, high level of risky activity, which leads to tissue breakdown and diabetic foot ulcer. Majority of the diabetic foot ulcers are from within out. And self-monitoring of the foot temperature is very important. Elevated foot temperature is a marker of the tissue injury. And what are the causes of the elevated plantar pressure? One, altered tissue properties, LJM, structural alteration and foot deformities, plantar callus, foot fractures, previous history of foot ulcer, faulty footwear, abnormal posture and gait, lower limb weakness, level of activity and body weight. And development of the diabetic foot ulcer in a neuropathic foot with the hammer toe deformity and the breakdown of the callus. These pictures he will display at the end. Yeah. The hallmark of diabetic foot in India is infection. So, non-infective causes, infective causes. Here in India, diabetic foot ulcer with the Magers, see the barefoot walking and massage and mud application and poultice application in the wounds. These are all some of the unwanted practices by our people. And at the end of the day, I would like to highlight one important point. We doctors who are interested in diabetic practice, we should allow our patients to come inside our chamber with the footwear. Most of us, we never allow. Most of the nursing homes, clinics, our security asks the patient to leave the footwear outside the clinic chamber. So if we want to really prevent the foot ulcer and amputation, this one thing all of us should do, should practice from tomorrow onwards. We should allow the patient to come inside the chamber with the footwear. This one thing will prevent most of the problems. Thank you very much for the patient listening.